Thank you for coming today. Last week's class, I think, was fun and was interesting. I sent you home with some things to think about, and I'm sure you talked to each other. I saw some of you in the office, and I said, what did you think? And I think everybody had a good time. It ran long, right? It ran a little long. We'll try and make it a little bit shorter today. Are there any questions about the things that we talked about last week? Anything that came up? As we're going through today, you may have some questions about, you may recall something from last week, and that's okay. So just bring it up. Remember what I said. Don't be afraid to stop me. Don't be shy. I expect you to ask questions. So last week we talked about preliminaries. How did you get here? How did it happen? Why is it easy? Why is it difficult? Why is it so complicated? And it is complicated. I think everybody understands that the whole process is complicated. And today we're going to talk a little bit about the labor itself. How do you go into labor? What do you expect? What's it going to be like? How long is it going to be? How are we going to manage it? What are we going to do to make it livable? How are you going to survive the day? Because all of you have heard stories. It was an awful day. It was terrible. My doctor didn't show up. I didn't know who was there. The pain was immense. I'd never had anything like it before. They didn't give me anything for pain relief. The anesthetist didn't show up. There are all kinds of stories. And then there are other stories that say, it was great, I had a wonderful day, I had no pain at all. So we need to sort that out. And you need to get some comprehension of what's going to be over the course of the day. So we're going to talk about the labor itself, and we're going to talk about pain relief, because there are really two really big issues today. What's my day going to be like, and how are you going to make it so that I can survive? Agreed? Those are really important issues. So let's talk about that. So at some point, everybody's going to go into labor, right? You're all going to go into labor. And we talked about dates last time when we said somewhere around 40 weeks is your due date. We said that between 38 and 42 weeks is term. Most people left alone go into labor at term or very close to it. And probably about 75–80% of people left alone will go into labor at the right time, sometime after 38 weeks. A smaller percentage will go into labor after. They'll go as long as 42 weeks. Probably their dates are wrong. So small percentage that we need to deal with, because we don't let anybody go really now to 42 weeks. We try to cut it off somewhere around 41 weeks or 41 weeks and a bit, and we'll talk about that. But the real issue is women that go into labor prematurely, because prematurity is a problem. So a small percentage are going to go into labor at 37 weeks or 36 weeks. It's probably not going to be a problem. There may be some breathing problems. There may be some feeding problems for the baby. 35 weeks, 34 weeks, also some issues. And then problems occur when it happens even earlier than that. So 28 weeks, 27 weeks, and then we have some serious issues. And we're going to talk about that, okay? So what's it going to be like? All of you are having contractions from time to time. I said that the uterus is a muscle, and muscles do two things. They contract and they relax. And your uterus from time to time is contracting. These are called Braxton Hicks contractions. And what they're doing is they're warming the uterus up. They're starting to position the baby, because every time you get a contraction, the uterus is practicing, and it pushes the baby down a little bit. The upper part of the uterus is all muscle, does all the work. The lower part of the uterus, so this is upper segment, lower segment is mostly muscle, some connective tissue, and it stretches to make room for the baby. And the lowest part of the uterus, which is the cervix and is inside the vagina, is all connective tissue, and all it does is it stretches. And right at the moment, it's the cervix which is the gatekeeper. It's keeping the baby in. As long as the cervix is not opening, this pregnancy is going to stay there. And from time to time, there are issues with the cervix opening up prematurely. And we'll talk about that a little bit too. Contractions. When you get these contractions now, these Braxton Hicks contractions, you feel your uterus tighten. It gets hard. And it gets hard on an irregular basis. You can get a contraction. And it might last for a long time, because the uterus is completely uncoordinated at this point. And it might last for a minute and a half, 2 minutes, and you feel the uterus hard. You put your fingers on and it's hard. And then it relaxes, it disappears, but it doesn't hurt. And these things come and go. And the closer you get to term, the more often they happen. And then eventually, it's going to become labor. But the big difference is going to be this. You're going to be walking, you're going to be shopping, you're going to be at work, you might be standing in the kitchen, and all of a sudden you're going to go like this. Oh my God. And you're going to get a contraction, and the big difference is it's going to be uncomfortable. It's going to hurt. And hurt is different things for different people, right? Somebody's going to bend right over and say, I've just been shot. And somebody's going to say, that was different. And then it disappears. And then it's going to come back. That's the hallmark. It comes back. And the contractions will get closer and closer. So some people are going to start out by having contractions. And the contractions start out usually irregularly. And you might start out by having contractions every 15 to 20 minutes. And you'll know the difference between a Braxton Hicks contraction and a real contraction when you're going into labor. First of all, the Braxton Hicks contractions are going to be earlier, and labor is going to be later. But the difference is going to be they hurt. And they often start out as a low back pain, and it comes around to the front, and you feel pressure. And it's uncomfortable. And that's the difference. Now, you've got some back pain already. Almost everybody complains towards term of some back pain. You weigh more. You've got this big uterus in the front that's pulling things forward, and you're curving your back a little bit more just to compensate so that you're not looking at people like this. And you're straightening yourself up like that so that you can at least look them in the eye. And that contributes to the back pain as well. But the pain of labor is going to be different. It starts out low, comes around to the front, you feel some pressure, and some girls have a lot of back pain. They have a lot of back labor. And that may be because of position of baby, and we'll talk about that also. So contractions. And the contractions will get closer and closer together. They'll start out maybe every 15 to 20 minutes, and then they'll become 12 minutes, and 10, and 8, and 5, and then about every 3 minutes, and now you're in business. So that may be the way it starts for you. On the other hand, that may not be the way it starts for you. Maybe the first thing that's going to happen is your membranes are going to rupture. Your waters will break. All of a sudden, you're at work, you're at home, you're in bed, and all of a sudden you feel water running out. And sometimes you just peed yourself. It's nothing more than that. Because all of you are going to the bathroom frequently now, about every hour, hour and a half, 2 hours. That big uterus is sitting on your bladder, and it's turned it into a little pancake, and you can't go 4 to 6 hours now. You're just going every hour, every half an hour, and just peeing small amounts. And sometimes you just lose a little bit of urine, and we have people come in to get checked all the time. I think my waters are broken. And it's just some fluid from the vagina, or a little bit of mucus, or they've wet themselves. But it's not membranes rupturing. The hallmark of your membranes rupturing is there may be some blood in it, maybe, but it's going to run down your legs, and it's not going to stop. So for some people, the first thing that's going to happen is your membranes are going to rupture, and it could happen anytime. And all of a sudden, you might get a gush, or you might just get this constant trickle, and your waters have broken, and without contractions. So some different ways that this is going to happen. Bless you. Labor is going to be different for all of you in terms of its length, in terms of its intensity. It's unique to you. The big picture is the same, but there are these unique components. For a girl having a first baby, the average length of labor is about 12 to 14 hours. That means if you live in Mississauga, you can walk here backwards. You'll make it. Usually when you're having a first baby, usually you don't need to come to the hospital by ambulance. First labor, about 12 to 14 hours, average. That means some of you are going to be lucky. It's going to be over in 2 or 3 hours. Wonderful. Once in a while, somebody walks into the hospital, first baby, and they're ready to go. But that's not the way it usually happens. It's usually longer. But if the average is 12 to 14 hours, and some people are going to be 2, 3 hours, then others understand are going to be 18, 20, 24 hours, sometimes even longer. We're not going to let anybody labor for 2 or 3 days. So the girl who comes in and says, I was in labor for 3 days, she wasn't in labor. She was in what's called the latent phase of labor. She was preparing. Her uterus was contracting, and they were little contractions, and we'll talk about the latent phase and the active phase of labor too. Okay? So this is what we're going to talk about today. So, first labor, 12 to 14 hours. Second baby, 6 or 7 hours. Third baby, 2 or 3 hours. Fourth baby, that's the one that delivers at home. That's the one that we talk about inducing you because your last labor was 2 or 3 hours and you walked in and you were fully dilated and you don't want to deliver at home or in the ambulance. So the last baby, it's quick. Our last baby, our fourth baby, my wife got into the hospital, got undressed, had a baby. That was it. No epidural, no nothing. She was mad at me. The other 3, she had epidurals. This time, no time at all. Got in, got changed, had a baby. That's it. She's still mad at me. 12 to 14 hours, that's a long time. What's the labor going to be like? Well, your baby has an opportunity to come out in all kinds of different positions. And we said last time that most of the time, in fact 95% of the time at term, your baby is head first. Now just because it's head first doesn't necessarily mean it's in good position. It's head first. If it comes out as a breech, that means the head is up. We'll talk about that issue. If it's going into labor with the baby sideways, that's another issue. And we'll talk about all of those things. So what's it going to be like? Okay, this is drywall, I think. And we'll make it real drywall, 5/8 inch. And you have to go through that wall. Now when you're in labor and you're having good contractions, your uterus is contracting every 2 to 3 minutes. Good and hard for about 45 to 50 seconds at a time, and the uterus is non-indentable. That means when I put my hand on the uterus and I push in, you say, ah, don't touch me, that hurts. Your uterus is hard as a rock. So we want good labor. Good labor for all that length of time. And that baby is coming through the wall, the cervix, and that vagina, which has never been stretched, head first. So here's the deal. You've got to go through this wall head first. And here's the deal. You've got to put your head on the wall, like that, or like this, or like that. You pick, because I don't know what position this baby is in right now. I can tell you it's head first, but I'm not sure whether it's face up or face down or turned sideways. And you put your head against the wall. That's your cervix, and it's pushing down. And you're not allowed to use your hands. You're not allowed to bang because the baby doesn't bang its way out. So put your head against the wall. And you have to push. And you have to push for 50 seconds at a time. Okay? 50 seconds at a time, and then you can relax. Now, what does a contraction feel like? What does it look like? Well, here's what it looks like graphically. No contraction. It's starting. Oh my God, it's starting to hurt. I'm going to die any minute. It's killing me. It's getting better. Thank God it's almost gone. I'm all right. 50 seconds. Okay? 10 seconds to build up. 30, 35 seconds for a peak. 10 seconds to relax. And you've got a little break. And then it's back. Every 2 to 3 minutes. So here you are. You've got your head against the wall. And you have to push. And then you relax. And you've got to put your head back in the same spot because the baby doesn't do this. I'm not happy with that. I'm going to change to this position. Once it's coming down in one position, it's going to stay there, and it rotates a little bit, but it doesn't flip around from side to side. So here's the picture. When you put your head against the wall, pick a good spot. Do not put your face against the wall. The ugliest babies in the world come out face first. Those babies that come out face first, and sometimes they do, you have a face presentation. And that face is being pushed against the cervix, and the nose is over here, and the eyes are like this, and the lips are like ducks. And the baby comes out, and I put it up on your tummy, and you say, ah, it's not mine! What is that? It's your baby. It's hard work, 12 to 14 hours pushing against that wall. What do you think is going to happen? So there you are, you're pushing, and you're having a contraction. It lasts for 50 seconds, and it relaxes, and here you are an hour, 2 hours later. And what's happened? Nothing, right? Nothing. It's going to take some time, unless you've got a head that's made of concrete. right? And you're really, really strong, you're pushing really hard, well then maybe you are going to get through in 2 or 3 hours. But what's going to happen is it's going to be a slow process. It's a slow process. And labor is about progress. Are you making progress? Okay? Are you making progress? And progress is measured in different ways. If the baby's head is high when we initially examine you and it comes down lower, have you made progress? Absolutely. And if your cervix is thick and hard and it becomes soft and thin, have you made progress? Absolutely. And if you start out and your cervix is a fingertip dilated and now it's 3 or 4 centimeters dilated, have you made progress? Absolutely. And all of those things are going to happen at the same time. All of those things are going to happen. But this is how they're going to happen. The first thing that's going to happen is the cervix is going to become soft and softer and thinner before anything happens. Now, usually I do an internal examination first time I see you. Come in early on, I examine you internally. And then I'm going to do another internal examination, another vaginal examination, right around term at 39 or 40 weeks. If you haven't gone into labor, I'm going to examine you at that time. And I'm examining you for a number of different reasons. Reason number 1, I want to make sure that the head is coming down. Number 2, I want to make sure that there's enough room again. Remember I said when I do that examination, it's not just about doing a pap smear, it's about assessing how much space there is. Can I drive a truck through here, right? Or is this going to scrape both sides as it's coming? Am I going to take the mirrors off the car, getting it in the garage? And I want to see also what the cervix feels like, because that's going to give me an idea of perhaps when you're going to go into labor and how long it might be. So if I find that your cervix, when I examine you at the beginning, is soft and thin, I'm going to say, good for you. You might go like a cannon. Your cervix is ready to go. You're already partially dilated. It's nice and soft. It's thinned out. You've already started to make progress. And your labor is going to be on this side, perhaps, of the 12 hours. On the other hand, if I find that your cervix is long and tight and closed, you're going to be on this side. Okay? My old professor used to say, it's, you know, if the cervix was like this, tightly closed, he said, it's tighter than a bull's ass in fly weather. You can't get a finger in there, right? So it's going to depend on what we find as to how things are going to happen. And I'm going to tell you, when I examine you at term, I'm going to say to you, you're lucky, your cervix is favorable, you're making progress, this is going to go pretty quickly for you. On the other hand, I might say, you know, if you want to go to the cottage this weekend, go, because your cervix is long and it's going to take a while. So this is going to control things, okay? All right, contractions. These contractions are going to soften up the cervix, it's going to thin, the baby's head is hopefully going to come down. It might or might not rotate to change its position a little bit, and then it's going to start to dilate. At that point, it's going to start to open up. So there you are against the wall, and you're pushing, and we're now 2 or 3 hours into it, and you've got a headache. Not much is happening. And 6 or 7 hours later, there's a dent in the wall. You've still got a headache, but now there's a bend in the drywall. It's starting to soften, and then finally it's going to crack, and you're saying, okay, I'm almost there, and then finally you're going to get your head through, and then you're going to wiggle your shoulders through, and that's how it's going to be. All right? And if you go into labor, starting with contractions, that's great. Come to the hospital. Don't come when you're having 20-minute contractions. I want you to come to the hospital when you're having contractions about every 5 minutes or so. Okay? So, time them. Call your husband. Say, I think I'm going into labor, and he's at work. He's giving you a number. You know how to get him. And say, you know, wrap it up. You know, I think I'm going into labor. I think you should come home and get me. And if he says to you, go to the hospital, I'll meet you there, it's a trick. He's not coming.
Go ahead and start without me.
Come and get her. Come and get her. And wait until the contractions are about 5 minutes or so, and then make your way in. Now, listen, it's a hospital. And in a hospital, things take time. Things take time. If it's during the daytime and you know that I'm in the office Monday, Tuesday, Thursday, call the secretary and say, I think I'm in labor. Come to the office. And I'll check you quickly and I'll give you an idea of what it's like, how you're making progress. Is this going to happen soon? Is it not going to happen soon? Should I send you over to the labor room or should I send you home? Because if you come to the hospital too early, they're going to send you home, and we're going to talk about that issue too. Okay? If, on the other hand, your waters break, and that's the first thing that happens, get yourself organized, don't panic, and make your way in. Once your waters are broken, water comes out, bacteria can go up, and the risk of infection starts to rise. And usually, once your membranes have ruptured, we would like you to be delivered within about 24 hours. Okay? So make your way in. And if you're not in labor and your membranes really have ruptured, we're going to get you into labor. We're going to start it up. Okay? So it's going to be different for everybody. If there's bleeding, different story. You see blood running down your leg, make your way in and let's sort out what the problem is. Let's see whether it's an obstetrical problem or a gynecologic problem. How much blood is there? Is this a concern? Okay? So it's going to be different for everybody. When you come to the hospital, you're going to go to the labor room. Okay? And it's not hard to find. It's on the main floor. You won't have any problems. Here's what I want you to bring when you come to the hospital. Not much. Do not come with a baby carrier. There's no baby yet. That's for the car. Leave it there. Do not come with a big packed suitcase. You're coming to have a baby. You are not going to Europe for 14 days. Don't do it. You don't need a whole bunch of stuff when you come to the labor room. I need you to bring very little when you come to the hospital. I want you to bring your health card. You need to register when you come in. You do not need to pre-register. Bring a small bag. You need a pair of slippers. You need a pair of warm socks. Bring some DVDs or some CDs if you want. They're little DVD players. So you can watch a movie while you're in labor. That's actually more for him than it is for you, right? You can bring anything you want to entertain yourselves. Some of you are going to make a birth plan. The minute you make a birth plan, it all goes somewhere, right? Have some ideas. One second, Julia. Have some ideas about what you want to do, but be flexible and understand that things can change along the way. Yes?
Do you need to bring a robe?
You know what? You don't, but if you want to, because you may want to go for a walk in the hall, it's probably not a bad idea. The little Hospital Johnny shirts that they give you are not terribly flattering, and they're open in the back, so you can always put one on the other way around like this in case you want to go for a walk. So here's the process. You're going to come in. You're going to get registered. The nurses are going to take some information from you, and they're going to put you into an assessment room and see whether you're in labor. There are a number of labor rooms. The labor rooms are for people that are in labor. They're not for people that are in pre-labor or think that they're in labor. So we're going to put you into an assessment room and see exactly what's going on. So we'll put you in, we'll put a monitor on, we'll listen to the baby's heart, we'll put a monitor on that also assesses the contractions and how often they are, and we'll see whether you're really having contractions every 5 minutes or 3 minutes or 8 minutes and exactly what's going to happen, and we'll see how uncomfortable you are. We'll see whether your membranes are ruptured, and this is going to determine whether you're going to be admitted at that point. And you're going to be examined. If I'm around, I'm going to examine you. If it's nighttime, weekends, holidays, and I'm at home or I'm out, and the nurses are going to examine you. And they're going to call me and let me know, and then we're going to make a decision together about what's going to be. The reason for this is we want to try and keep the labor rooms for laboring people. That way everybody gets a bed. And this was an issue years ago, and it's still a little bit of an issue now, but a bigger issue when I was chief about 10, 15 years ago. And people were coming in indiscriminately. Doctors were just sending their patients in, and you would be a fingertip dilated and you'd get a bed, and you would be 2 centimeters dilated and not in labor and you would get a bed. And the beds would fill up, and then somebody would come in 7 centimeters dilated and she'd have to get a stretcher because all the beds were filled. It really wasn't fair. And if I walked into somebody else's room and I said, listen, you're only a fingertip dilated and we need your room, the patient would often say, you're not my doctor, you can't send me home. And so there were issues. And so I changed the rules, and I said if you're not in labor, you're not going to get admitted. You can go for a walk, you can go to the mall, you can go to your mom's, but the operative word is you're going to go. And then you'll come back. And this is the girl who's in labor for 2 or 3 days. This is the girl who comes to the hospital, and when we examine her, she's a fingertip dilated and she's having 8-minute contractions. And we send her home, and 12 hours later she comes back and she's a fingertip dilated and she's having 5-minute contractions, and we send her home. And then she comes back 12 hours later, it's now we're around the clock, and she's a fingertip dilated. The cervix has softened a little bit, but by now, we got to have mercy, right? We can't keep sending her home. Now, obviously, if you live an hour away, we're not going to send you home. We'll send you to the waiting room. We might even send you upstairs to the antepartum floor. If it's a snowstorm outside, we're not going to send you home. We're not going to do stupid things. But if you live 20 minutes away, a half an hour away, and you're really in early labor, you're probably going to be more comfortable at home. Because what happens when you get into a labor room is you start looking at the clock. And you're saying, he said 12 to 14 hours, right? It should be like Las Vegas casinos where there are no clocks. You don't know what time it is. You don't know how long this is taking, okay? Now, be reasonable, okay? You've got a watch on. You can see how often your contractions are. You do not need to come to the hospital with a stopwatch. Now, I've seen husbands come in with a clipboard and writing down, the time of the contraction. Her last contraction was 2 minutes, 44.83 seconds ago, right? Do not do that, okay? Do not do that. If I come in and I say, how often are you having contractions? You can tell me I'm having, 2 3-minute contractions, or I might look at the monitor, because you might have a monitor on, and it's going to tell me what's happening. So that's the process, okay? That's the process that everybody's going to follow. When you come in, nurses are going to take some information. If we send you in, if you come in and they take all that information and then send you home, when you come back, it's going to be a lot faster, all right? So that's going to be the process when you go into labor. Come to the hospital. Let me know if I'm around. If I'm not around, the nurses are going to page me when you come in. They'll get you assessed. Then they're going to call me and tell me where we are in the game, and then we're going to bring you in. Okay, is that fair? When you get admitted, the rooms are private rooms. Some of them are a little bigger than others. All of them have private bathrooms. Some of them have bigger showers than others. The showers are really great. We don't have whirlpools, okay? Not this hospital. Maybe one day in the new hospital, but not this hospital. So showers. And very often, if you're in labor and it's not to the point where you need anything for pain, we'll say, go sit in the shower. Turn the hot water on. It'll relax you a little bit. It helps a great deal. It's their hot water, not your hot water. Let it run. Don't be shy, okay? You're not allowed in the shower with her. Although if you close the door, nobody looks, what the heck, go do it. All right? In the beginning, it's not going to be that uncomfortable. It'll get a little more uncomfortable afterwards. So the nurses have taken their information. I have a little thing that I like to do, and that is that I want each of you to have an enema when you come in. Okay, an enema is they put some water in your bum, and then they send you to the bathroom and you go to the toilet. It's to clean you out. And the reason for that is, when you're having a baby, you're going to feel a lot of pressure. And when the time comes to push, you're going to be using those same muscles to push the baby as you do to poop. Okay? And I want it to be as clean as possible.
Us too.
We're not going to pretend that a delivery is a sterile procedure. It's not sterile at all. It's a semi-contaminated procedure. Okay? The vagina is not sterile. You can't sterilize it. But we want to make it as clean as possible. So I'd like you to have an enema just so that when you're pushing, you're not pooping at the same time. I don't want to know what you had for dinner yesterday. Okay? I don't want you to smell up the room. I don't want you to embarrass yourself. And I don't want you to be pooping at the same time the baby's head is coming out, especially if we've made an episiotomy or there's a tear, because the risk of infection is there. The risk is not big, but the risk is there. All right, so if it's doable, everybody's going to get an enema. I am not going to shave you at that time, although some of you may want to prepare before you come to the hospital. If you want to do a little Brazilian wax, that's okay with me. At the time of delivery, we'll do a little shave prep, but that's all. If you're going to have a cesarean section, we'll do a little shave as well. But we're not going to shave you completely. That's not going to happen, okay? You're in labor. You're having contractions. You're there. You're there. And it will be different for each one of you. How long it's going to be, how you're going to cope. And in a few minutes, we're going to talk about pain relief, but I'm going to backtrack a little bit now, okay? What if labor isn't exactly the way we talk about it? What if it continues to be irregular? What if your contractions are not good? What if you're not making progress? Because it's all about progress. We may have to help you a little bit. So we need to talk about induction a little bit and stimulation, okay? What happens if you don't go into labor? What happens if we're 41 weeks and we're not there? What happens if we go early? So I want to talk about these issues a little bit now. So the first one that I want to talk about now with you is I want to talk about what happens if you get to 41 weeks. What happens when we get to 41 weeks? What we do is we look at the dates and we say, are we sure? Are we really there? So we'll talk, remember we talked about the dates and we said sometimes the dates are not really what they are because it's not a 28-day cycle, it's a 35-day cycle. So we'll look at the ultrasounds and we'll make ourselves happy that we're really at 41 weeks. And if we are, I'm going to make a phone call over to the hospital and I'm going to book an induction date. And we're going to say, okay, this is as far as it goes, and we're going to bring you in and make you go into labor. Now, there are different types of inductions, okay? First one is a casual induction. That means there's no good reason for this. And usually I don't do this with girls that are having first babies. I might do it for a second, third, or fourth baby. Girl comes in and says, my last labor was 2 hours. I just made it to the hospital. We might think about bringing you in to induce you the next time because we don't want to be in that same situation. We want things a little bit better controlled. So a casual induction means is there's no really good reason. You might say, I really would like my husband to be at the delivery, but he has a crucial meeting next week. Is there any possibility that we can do it now? So there are issues, and the bottom line in all of it, whenever we do this, is it safe? Is it safe for you? Is it safe for baby? Okay? So casual induction. Second, an indicated induction. There's a reason. I need to bring you in for a reason. I'm not happy with how the baby's growing. I think the baby's too big. You may have diabetes. There may be a medical issue. You might have toxemia. I need to bring you in. It's indicated. I need to do it today, tomorrow, the next day, sometime in the next 48 hours, I'd like to bring you in. And then there are emergency inductions. I need to bring you in now. You don't even get a chance to go home. I examine you, your blood pressure's high, I said you've got preeclampsia, which is toxemia, and I say, okay, you need to have the baby today. Phone your husband, call him, tell him what we're going to do. He can go home and get your stuff, bring it into the hospital, but you're not going to go home. You're going straight across to the hospital. So different types of inductions, okay? We're going to make you go into labor. Now, the low priority inductions, a casual induction, we book it, we book you a spot, and usually we have 2 or 3 spots every day, and you can be bumped out of that spot. So you could come in and all of a sudden we find that there's somebody who's got a higher priority. That higher priority is going to bump you out of that spot. And I think that that's fair. We have to look after people who need to have it done as opposed to people who want to have it done. All right? So understand that you, instead of being done 8 o'clock in the morning, it's possible that you may get called back at 4 o'clock in the afternoon because you are a lower priority. If we're going to induce you, we're going to make you go into labor. There are different ways to do it. And what we're going to do is going to depend on the mechanical situation. What's the cervix like? Where is the baby? Have we had any changes in the cervix or none? So if there are no changes in the cervix, we're probably going to put in some Cervidil or Prenatal. It's a prostaglandin, it's a hormone. And what it does is it does 2 things. Number 1, it softens up the cervix. So if the cervix was thick and hard, it softens it up, and it takes time. This doesn't happen right away. It can take 12 to 24 hours to prepare the cervix. And then for other girls, it makes you go into labor. It starts contractions. So that's one way. Another simple way is just to break your waters. So sometimes we'll induce somebody who may be 3 or 4 centimeters dilated, and all we need to do is break your waters. I've done it. It's just about the same as if Mother Nature did it, except I started it. Didn't rupture spontaneously, it happened because I started you. So sometimes that's all we need to do is just break your waters. And then other times we'll start some oxytocin. So we start an intravenous, we put some oxytocin in the intravenous. Oxytocin is the hormone of labor. Where does it come from? It comes from your pituitary gland. It goes into your circulation and it binds to receptors in the uterus and it makes your uterus contract. Well, you've got oxytocin all the time. Why aren't you in labor? Well, a couple of reasons. Number one, progesterone. Remember I said progesterone is the hormone of pregnancy, quietens the uterus.